Okay, so to pick up on some of the considerations for treatment as well as some of the non-SSRI, SNRI treatments for anxiety, OCD, PTSD, beyond our SSRIs, SNRIs, and TCAs, there are a number of classes I want to spend a little bit of time with. So we have our benzodiazepines, which, if you look at the sleep lecture, has some information regarding the role of benzodiazepines there. But there is some role in acute anxiety. Then we have some other products such as buspirone or buspar hydroxyzine, which is also referred to as Atarax or Vistarol, propranolol, which is also referred to as Inderal, pregabalin or Lyrica, and there are some roles for other products as well, such as atypical antipsychotics, sometimes some other antidepressants. So there are some pharmacological options beyond our traditional antidepressants for anxiety and related disorders. Psychotherapy, exposure response prevention, EMDR, all of these non-pharmacological options can also play a pretty significant and useful role in treatment of anxiety and related disorders as well. So the things that we're going to look at when we consider the differences between how we would treat a person with anxiety or something related versus someone with major depressive disorder, particularly with generalized anxiety disorder, is because of the potential anxiogenic or anxiety-provoking effects of initial treatment with an SSRI or SNRI, we'll oftentimes start at a lower dose. However, in a lot of cases, people might need higher doses to obtain the same level of efficacy, particularly in conditions such as OCD. In OCD, we often won't start at a lower dose, but generalized anxiety, yes. But they may need higher doses compared with people who are being treated for major depressive disorder. Again, therapy always appropriate. So talking about benzodiazepines, a little bit of this is review if you've looked at sleep lecture that I've posted, but benzodiazepines have a number of different potential functionings in the body. So they act as what we consider a centrally acting sedative. So it has sedation properties. It also has anxiety relieving properties. So it's an anxiolytic. Acutely, or in the short-term sense, it can act as an anticonvulsant. So we will use benzodiazepines, notably midazolam, diazepam, and lorazepam potentially for what we call status epilepticus, which is a condition of intractable seizures. It also is a central muscle relaxant. So people who have spinal cord injuries that have spasticity associated with that may benefit from using benzodiazepines as well. So there are a lot of potential really useful medical reasons why someone might use a benzodiazepine. The general indications: anxiety disorders, sedation, seizures. We also can help prevent the development of seizures and alcohol withdrawal, which we've talked about before, as well as relief of muscle spasms. Pharmacologically, benzodiazepines work on the GABA receptor. Now, they aren't similar in structure to the GABA molecule in the sense that benzodiazepines don't bind to the same site as GABA does. So if you have your kind of competitive agonist type scenario that looks like GABA, it would bind at that same site. It actually binds at a separate site. So it binds between the alpha and gamma subunit. And how this works is it will increase the frequency with which that channel, that GABA receptor channel, opens. And when that channel is opened, chloride ions move from outside the cell to from outside the cell to inside of the cell, right? So we have our activation through chloride here that moves inside of the cell. So this will cause a inhibitory transmission, right? GABA is one of our major inhibitory neurotransmitters. So when that happens, we see all of these potential effects. Okay. Now, different than some other medications like barbiturates, which actually increase the duration with which the chloride channel is open, benzodiazepines will increase the frequency. So it'll open for the same amount of time, but just more often. Okay. So If you like words more than pictures, what we see is it binds to GABA receptors between the alpha and gamma subunit, and it acts to increase the affinity of that receptor to GABA that causes that chloride shift and inhibits excitatory activity. Therefore, it's inhibitory. Okay. There are a couple different receptors that may have different activities. The things that we see more tolerance developed to are with our benzodiazepine 1 receptors. So people over time may be less sedated, may have not as robust seizure control when using benzodiazepines. But with our benzodiazepine 2 receptors, which produce anxiolysis and muscle relaxation, those tend to be less likely to cause or have tolerance associated with them. Now, the challenge that we see in anxiety is people will often connect sleepiness with anxiety treatment. So if the sleepiness starts to get less noticeable, people may feel as if the anxiety relieving effects are diminished too. So that's something that sometimes we have to kind of suss out and work through to determine if it's really that the anxiety relieving effects are being reduced versus the sleepy effects. So when we give a benzodiazepine, it is a CNS depressant, and there's a number of different things that happen with escalating doses. So with our first kind of lower dose, we can see some sedation. So someone might feel a bit slowed down, a bit more relaxed. Further down the line, what we'll actually see is hypnosis, where people fall asleep. Now, benzodiazepines such as midazolam are used during procedures as an anesthetic. At higher doses, we do see what we would consider an anesthesia effect, where people will not have a significant response to painful stimuli. Further on down the line, we can see people fall into a coma. So basically, a lot of their functioning starts to decline. They may not be able to protect their airway and breathe appropriately. So really in that anesthesia coma state, that's where we might see that. And with high enough doses, it can result in death. So there is some concern. Whoop, wrong direction. There is some concern with overdose. However, in general, it's fairly difficult to take enough benzodiazepine to result in death, but a lot of overdoses connected to benzos are multi-substance in nature. So people might consume alcohol and opioids and benzodiazepines, and that is a lot more dangerous than a singular substance. So we have different formulations of drugs. So we have comparisons with our long-actings. So chlordiazepoxide, so on the left side, chlordiazepoxide, clonazepam, chlorazepate, and diazepam are our longer acting benzodiazepines. So these can be used more throughout the day, have longer duration of effect. Where alprazolam, temazepam, trazodone, oxazepam, these are really shorter acting. They tend to be used a bit more in very short needed acute anxiety scenarios, as well as for sleep. From a side effect perspective, these are CNS depressants, so we can see some sedation, some decrease in your respiratory drive, so the frequency with which someone might breathe will decrease. We can see psychomotor impairment. This can result in falls, increased risk of fractures in the very young and very old. This can also cause confusion and memory difficulties. And for some people, they can have what we would consider a paradoxical reaction. And what that would mean is someone might become more disinhibited, kind of like, when some people consume alcohol, they may become more outgoing, less reserved as a result of the alcohol exposure. We can see that sometimes with benzodiazepines as well, because it's actually pharmacologically kind of similar to alcohol. We can also see amnesia. So people can sometimes forget or not recall pieces of information that they experience. It can also be anterograde as well as retrograde, so before or after the timing of taking the medication. And there is a risk of dependence, abuse, misuse, developing a substance use disorder. So we do have to take that into consideration. Now, because of that risk for disordered use, we want to take into consideration the individual's history and what those risk factors might be for using benzodiazepines inappropriately, because they certainly do have a therapeutic benefit, but for some people that risk versus benefit is going to be a little bit different. So if someone has a current or history of substance use, particularly if it's alcohol use disorder, then we might try other anxiety medications first, and if we do use these products, we'll watch pretty closely. If we minimize treatment duration, usually to 3 to 6 weeks or less, obtain those good medical histories and monitor for diversion. So looking at their use history, their refill history, if they're getting similar products from multiple providers or multiple sources or pharmacies, those would be potential flags to, investigate their use pattern. And the risk really with benzodiazepines over time is withdrawal. Now we can see withdrawal from a number of substances, but alcohol and benzodiazepine withdrawal can be some of the more dangerous types of withdrawal syndromes that we can see people come in with. Most of the time when someone experiences withdrawal from a benzodiazepine, though, it's unpleasant but not so dangerous types of symptoms they may experience. So they can have some rebound symptomatology, such as difficulty sleeping, feeling irritable or anxious. So again, we're treating that sometimes. We're managing those types of symptoms with benzos, but they can sort of rebound and come back with a vengeance during the withdrawal period. People can also experience muscle aches, tremors, loss of appetite, which is anorexia, hypertension, so increased blood pressure, increased heart rate. Now, for some people, even in mild to moderate withdrawal, they can become a little confused. They can sometimes develop symptoms of depression. They can have significant nausea and changes in their reflexes, so heightened reflexes, changes in vision. Rare but can potentially happen is people can develop seizures, because benzodiazepines affect our seizure threshold. So suddenly discontinuing them, we're more sensitive to seizures in that state. Similar to alcohol, we can have a delirium, kind of like a delirium tremens. People can develop psychosis and catatonia as well during benzodiazepine withdrawal. So if someone is, if you have a 60-year-old lady that comes in that's been on 30 milligrams of diazepam or Valium every day for years, we are not stopping them that day. We're going to taper very slowly and monitor for those signs of withdrawal to help reduce any risks associated with that. On the other side of the coin, overdose can be a concern as well. So we mentioned this already. There is a reversal agent for benzodiazepine overdose called flumazenil. However, it's not frequently used in practice because there are some risks connected with using flumazenil. So flumazenil, if someone has dependence on benzodiazepines, can sometimes induce seizures. If they have increased intracranial pressure, so the pressure in their brain is elevated from trauma or something, that can be potentially dangerous. And a lot of times overdoses relating to benzodiazepines may be multi-substance in nature, so the benefit of the flumazenil can be pretty minimized in those scenarios. But there is a reversal agent available. In terms of their place in therapy, they should be used, especially initially, acute. So if someone is experiencing crisis level anxiety from their panic or generalized anxiety disorder, then it may be appropriate to prescribe benzodiazepines for that rapid relief. But those individuals should still be on some sort of maintenance treatment, typically some sort of antidepressant. Maximum of 6 weeks, and then taper the dose. Now, some people, particularly with panic disorder, may require more scheduled dosing type scenarios or longer term use, but that is not the first thing that we should reach for because the risk versus benefit profile doesn't really favor that treatment modality. We don't see, in most cases, very effective treatment of the symptoms of anxiety or the condition of anxiety with benzodiazepines. I liken it to someone being stranded in the ocean. You give them a life preserver, so that's going to keep them above water, but you still need something to offer them to get them to shore, right? So that's where psychotherapy, antidepressants come into place too. The benzodiazepine is keeping their head above water, but we got to get them to shore using something else. So now that we spent some time with benzodiazepines, there are a number of other agents that we're going to talk about in a separate video.